Patients often come in and ask, is LINX right for me? And so whenever we think about surgery for a patient, surgically intervening on a patient with GERD, I think about three things. And one, if you think about it as a triangle, as is noted here, we need to prove that there is objective evidence of reflux. I certainly don't want to look you in the eye as a patient and say, oh, it sounds like you might have GERD, let's just go ahead and do an operation and see if it works. That's not the way we operate. So what we want to do is we want to objectively quantify your GERD. And so we can do that in several different ways. One is through a pH probe, testing and see if there is in fact a lot of reflux coming up into the esophagus. The other way is through endoscopy, where we can go down and look and see physical evidence of damage to the esophagus or the lower esophageal sphincter. Do you have Barrett's esophagus or, heaven forbid, cancer? Next, we need to look at the structural anatomy. Do you have a hiatal hernia knot? And we can do that in several different ways too. One is the endoscopy that we already talked about. The other is doing a barium esophagram, where you swallow some liquid and it goes down and we can really get a good look at the anatomy. So we want to know what is the structural anatomy down around the area where we would do the operation. Finally, we need to know how well your esophagus is working, because we need to know if it's able to open up the LINX when you're swallowing food. And so we can do that in several ways as well. One is through our specialized barium esophagram, where I actually call it a marshmallow and bagel swallow. We have you swallow little bits of marshmallow and bagel, and we know that if you can swallow those without difficulty, then we are able to open up that LINX and you don't have any problems with your esophagus. The other is formal manometry, where we go and through a series of 10 small swallows, we're able to see what the pressures are and see if there's any other underlying esophageal disease. So we have a whole host of diagnostic equipment that we can use and to figure out if you're a great LINX candidate. The LINX candidate is going to have plus or minus damage to their esophagus, but we can usually deal with that, and in fact LINX will heal esophagitis if it's present. We have to have normal esophageal motility or a normally working esophagus in order to open up the LINX, so that is an absolute requirement. And then finally, we need to know what the anatomy is, and currently it's approved for smaller hiatal hernias, so a hiatal hernia that's 3 centimeters or less, although I'm participating in trials going on right now looking at larger hernias. So hopefully that will in the future be another option for patients, but currently it's approved for smaller hiatal hernias. So that's what the LINX patient looks like. Again, in studies done at our institution and at others, we noticed that vast improvements in quality of life after performing the LINX procedure, and this seems to be durable both at 3 and 5 years out. We're having 5-year data now coming out about the LINX procedure. So it's durable, it's effective, and it has fewer side effects from the Nissen. And just to preempt a question that often gets asked, one of the other nice things about it, downside of the Nissen is that you can't vomit with a Nissen, and with this you absolutely can, because it's a pressure-based system, so you can, again, we're maintaining more of the normal physiology of the stomach, sphincter, and esophagus, and so it allows for that and allows patients to vomit.